Hello, and thank you so much for joining us today. We're going to learn how to describe turbulent blood flow. It's just amazing. By changing to a high frequency cardiac probe and placing it in the suprasternal notch, there's a whole world of things that can be seen that just haven't been noticed before, such as transient low velocity blood flow. And we're also going to see high velocity accelerations and see how they work. And first off, we're going to talk about complex flow reversal and see how that might give us some clues as to how turbulent blood flow works. So this is a 12-year-old female. She weighs 214 pounds, and I need another way of following her. Not going to be able to get much echocardiographically in her if she gains more weight. So here's the jet, and here we can see the flow reversal. So let's put a sample volume right here and see what we can learn about turbulence. So the sample volume is placed right here, and we can see this fluctuating velocities with these spikes here, and it even continues into diastole. So it's likely that this blood flow is coming from here. Okay, so we can see a little trace of aortic regurgitation, but it's just going too fast for us to see, so we'll have to go frame by frame. So here's our introductory frame. We can see systole is just getting started. There's some swirling going on in the ascending aorta. And here we can see some disturbed flow. Looks like we're seeing some circular motion here. And the jet is starting to form. We see the turbulence. Again, the swirling where the blood is coming back and joining the jet. Whoops. Now we're seeing disturbed flow again. And this could be an important point in the transition of laminar to turbulent blood flow. Okay, the jet is starting to form again, and again we have this swirling and reverse flow. Here we're at peak systole now. We can see a very well formed jet, and the flow continues. So even in diastole, we're still seeing reverse flow, just like we saw in the pulse Doppler. And now we're starting to see the aortic regurgitation again. So this shows the laminar blood flow that we recorded with continuous wave. There's no delay. There's no low velocity blood flow here. And there are a lot of different velocities. You can see the LVOT here, but still it's primarily laminar blood flow. So we're going to march up to the proximal left common carotid, and we can see that there's been quite a change. We now have a transient low velocity blood flow, and that's followed by these high velocity accelerations or spikes. And then there's another transition. We're going to see in the distal left common carotid, we're going to see this very low velocity blood flow here, well under a meter per second, but this transient low velocity blood flow that we saw over here is now here. And I want to point out that in this moderate case, the peak velocity is 3.9 meters per second, and the aortic gradient peak velocity is 3.9 meters per second as well. So we're going to march up the aorta now. We're right here. The sample volume's right here. It's still pretty laminar, but starting to break up. No evidence of transient low velocity blood flow. And when we get up to the ascending aorta, we can see the transient low velocity blood flow starting to develop, and also we're seeing these spikes here. So we're seeing the velocities fluctuate in the aorta. So at 64 millimeters, it's not so much. At 42 millimeters, we're starting to see some changes. And when we look at the descending thoracic aorta, we can see this marked low velocity blood flow that's similar to the anacrotic pressure pulse pressure tracing that you see in a cath lab. And then the blood flow, the pulse wave begins to reform. So we're back to our mostly laminar blood flow. So this is a vascular M mode. We're using minimum depth and maximum magnification. In a normal, we see this nice brisk upstroke. There's some acceleration we see here. There's the early diastolic flow reversal we see here. And we see these lovely horizontal lines showing us how the blood is flowing. And over here, we can see that there's turbulence, flattened or blunted waveform, and this artifact is created by the turbulent blood flow. We can also see some fluttering of the walls of the left common carotid. Okay, so this has a lot of applications in aortic regurgitation. This is a 22% distension in the artery, and that has been shown to be consistent with severe or moderately severe aortic regurgitation. And over here we can see aortic stenosis. It's flat, there's flutter. We can see this long period here, which is associated with the transient low velocity blood flow. These horizontal lines are likely the high velocity accelerations or spikes. And here we're seeing flow reversal and the dicrotic notch. Hypertension came as a huge surprise to us. It looks at first like there's paradoxical septal motion, paradoxical arterial wall motion, but that would be impossible. An artery can't get smaller in systole. So what we're seeing here is the patient has a blood pressure of 154 over 100, and the artery's just too stiff to pulse. So there's not much change in the diameter here. But there is movement of the artery. The artery is jumping forward and then falling backwards. And we can see the horizontal lines show horizontal flow. But now we're seeing flow in two directions. It's both horizontal and inferior. And now the blood flow is both horizontal and superior. There's a brief period here where we see horizontal blood flow again. In cardiomyopathy, we can see the double pulse in a severe cardiomyopathy. Right here is systole, and then systole ends and we get a long period of flow reversal, which is something I completely unexpected, that flow reversal would be an important part of cardiomyopathy. Then we get the secondary pulse, which is actually occurring in diastole. So I was wondering what would this look like in a patient with symptomatic aortic stenosis who's experiencing new onset of dizziness. And this was also a big surprise. This 38-year-old woman has no pulse at all. She has, there's no distension, there's no retraction, there's no turbulence in the blood flow, and this could be an important indicator of change in the severity or the hemodynamics of aortic stenosis. We're coming to the most important part of our talk. We're going to see how velocity changes a normal proximal carotid Doppler. Normally you have a primary systolic wave and a secondary systolic wave and early diastolic flow reversal. Notice how there's no fluctuation, there's no beat-to-beat variation. We're going to see how the primary wave becomes suppressed while the secondary wave becomes augmented. Okay, we're at 2.02. Even in a very mild gradient, we can start to see fluctuating velocities and augmentation of the secondary wave. However, the primary wave is still intact and there's no fluctuation in the primary wave. Okay, we're up to 2.41 meters per second. Again, we can see the fluctuating velocities, these spikes here, but the primary wave is still intact and not much variability. Okay, we're up to 2.61 meters per second, and now we're seeing something more interesting here. The primary wave has been suppressed. It's now a low velocity, less than 0.7 meters per second. And the number of spikes and the height of the spikes is increasing, but not quite up to 2.61 meters per second, but getting there. Okay, now we've gone up to 2.9 meters per second, and we can see an interesting thing. The primary wave is nearly completely suppressed here, and it is fluctuating. So we have fluctuating in the secondary wave and fluctuation in the primary wave as well. Okay, up to 3.37, really gotten flat primary wave here. The secondary wave again is showing the spikes and the fluctuating velocities, and the velocity is not quite up to the 3.37. All right, we're at a higher velocity now. There's a lot more inertia. The primary wave has changed now. It's wildly fluctuating, different shapes, heights, a lot more spikes, sharper spikes, but something else has changed. The peak velocity is now equal to the peak velocity here. And finally, we have a severe obstruction, 5.5 meters per second. We can see the spikes are very tall, very high frequency, and the primary wave is wildly fluctuating. It's 83 milliseconds here, 60 milliseconds here, 65 milliseconds here. And look at this first spike here. We're going from less than a meter per second up to above 6 meters per second in just 10 milliseconds. That's a very rapid acceleration. And notice that the peak velocity here exceeds the peak velocity here. So in conclusion, since there are no air-filled structures to block the ultrasound beam, this method could provide a practical alternative in the serial study of obese patients with aortic stenosis. And I'd just like to add, it's amazing what you can learn just from looking at a pulse. Thank you so much for tuning in.